Hello, friends. We all know septic shock continues to challenge us with high mortality despite advances in antibiotics and organ support. The real battle lies in dysregulated immune response, a storm of inflammatory mediators followed by immune suppression. Heme absorption offers an approach by directly removing these mediators from circulation, aiming to restore balance. But this therapy is not without controversies surrounding this. So today we'll explore the rational evidence and place in managing septic shock. Allow me to share my slides, please. So, as you all know, I'm Dr. Bharat Jagyasi, Examination Secretary elect, Indian College of Critical Care Medicine by ISCCM, and I'm Director Critical Care in Kokilaben Hospital, Navi, Mumbai. So, when we talk about the heme adsorption, very important to understand what exactly it does. So, by definition, it's a blood purification technique that removes cytokines and endotoxins from circulation. And what it does is by absorbing materials used to bind and remove inflammatory mediators, and eventually it modulates the immune response in sepsis to prevent the organ damage. And there are various filters which have been used. We all are aware of it, so we'll just go through it one by one. So there's something called a cytosorb, which does unselective absorption of hydrophobic molecules within 5 to 60 kDa range. And what it does is absorbs various cytokines like interleukins, tissue necrotic factors, bilirubin, myoglobin, toxins, and various therapeutic drugs as well. And it's been very widely used in septic shock and other severe inflammatory states like liver failure, rhabdomyolysis, and intoxications. Again, we have HHA 330 and HA 380. It again causes unselective absorption of hydrophobic materials molecules within 10 to 60 kDa, and it does the same kinds of absorption target what the cytosop has, and again the use is also almost similar. Then we have the auxiliaries, which does helps in removal of cytokines and endotoxin by membrane binding. The device also works as a conventional hemodialysis filter. So its targets are basically endotoxin, various pro-inflammatory and anti-inflammatory cytokines, and is used in septic shock and other severe inflammatory states as well, and endotoxemia. Then we have the pentosorb, which is a selective absorption of CRP, and the absorption target, of course, is a CRP, and is used in clinical condition where the CRP is very high, like systemic infection, post-cardiac arrest syndrome, myocardial infarction, rheumatic disease. Then we have the syrup. This is very interesting. It causes absorption of toxins, inflammatory cytokines, and a wide range of bacteria, viruses, and toxin and disease-causing sepsis mediators. So it could be also be used for the absorption targets of various bacteria and viruses like Staph aureus, MRSA, Clem pneumonia, E. coli, Streptococci, Enterococcus faecalis, Faecium, Acinetobacter, Staphylococcus epidermidis, MRSA, Streptococcus. Then various cytokines like IL-6 and tissue necrotic factor. It could be used in severe bacterial and viral infection. Then we have the toramycin, which has a selective absorption of endotoxin to polymyxin B, which is covalently bound to polystyrene fibers in the absorber cartridge. And we understood the target. It's been very widely used in the sepsis or septic shock caused by gram-negative bacterial infection and endotoxemia. So we need to understand what are the physiological basis of the various heme absorption technique which have been used. So we all know there's something called a cytokine storm. So it modulates the storm by removing the excess in anti-inflammatory mediators and prevents overwhelming immune response and restores immune hemostasis. It can also help in removal of the endotoxins, which captures bacterial endotoxin, reduces trigger for the inflammation. And what we anticipate out of this? So of course, there's a cytokine removal. So it controls the storm very well. And we tend to achieve the hemodynamic improvement by increase the mean arterial pressure and the reduced vasopressor requirement, and which will improve the end organ functions. In respiratory, it will improve the oxygenation, reduce ventilator support. And in terms of renal, it will potentially help in preservation of kidney function, reduce the incidence of AKI. This is what we look into. So before we talk about how does it act and what the various studies are talking about this or saying about this, so we need to understand how the immune system dynamics work in sepsis. So we have the pro-inflammatory and the anti-inflammatory response to the system. So there's an initial response, which is hyperinflammatory phase with cytokine storm and systemic inflammation, and then followed by the transition phase, which is a mix of anti-inflammatory and pro-inflammatory response and occurs simultaneously. Late phase, which is an immunosuppression, dominates with increased risk of the secondary infections. So the initial response is the innate immunity versus the late response, which is acquired immunity in sepsis. So innate immunity is response within hours, where the neutrophils and macrophages comes in play, and the pattern recognition receptors is there. So it's an overall response without the pattern recognition. Acquired immunity is more of a antigen-specific response, and of course, it's a delayed one, and where the T and B lymphocytes comes in play, and the interaction is about the cytokine crosstalk, antigen presentation, the coordinated response. So, as we spoke about the innate immunity, so initial 4 hours, neutrophils get activated, the inflammatory mediators get activated, followed by the macrophages, and next 24 to 72 hours, it reaches to its maximum threshold, and the dendritic cells present antigens, and after 72 hours, or the 22 of 24 hours, the adaptive immunity mechanism comes in play, where the acquired immunity comes in play, which is more specific. T cell identifies the specific pathogen components. Process takes 3 to 5 days, and there's a lymphocyte proliferation and antibody production and cytokine killing, eliminating the threat. So, what comes next is the immune paralysis. That is, it is a mechanism and consequences of the innate and the acquired immunity. So, it is due to the endotoxin tolerance, that is, repeated exposure to bacterial product decreases the cellular response, and the leukocytes become refractory to the stimulation. There's apoptotic cell death due to massive lymphocyte apoptosis occurs, and there's an altered gene expression, that is down regulation of HLA-DRA. So what we look into is there's an initial response, there's a temporal immune response pattern to the sepsis. So initial response is pro-inflammatory cytokine storm, followed by the transition phase, which is a balance shift, and then there's the immune paralysis, which leads to the development of the secondary infection. So what exactly becomes is we have the hyperinflammatory phase, then we have the immune suppression phase. So what heme absorption does is this hyperinflammatory range, which is a toxic range, it brings down to the something at this level, so that the organ damage isn't prevented, and it actually plays the role of the immune system. It doesn't overtly becomes active and damages our organs on its own. So optimal timing of heme absorption is what is required. So we have the early phase where there's a cytokine storm and entoxemia, and most beneficial timing is for this. This is this time where it's maximum going to be beneficial if we intervene at this time. Then there's an intermediate phase, which is already a balanced area. If I end up using in the late phase, that is limited benefits as immunosuppression dominant, and at that moment we have to consider other options. So it's not all about that. Even the septic patients are different. So we all know, do all septic patients present the same way? The answer is clear cut, no, they don't. So presentation varies. They can have the different various presentations. Someone will respond just with the fever, someone will have the septic shock, and few patients will just present with the multiple organ dysfunction to start with. And complications are also dependent on that. And treatment implications would also vary because they will have the organ support system. Someone would be just on the ventilator with a respiratory support, or they may require a vasopressors as well. And there's a profile of the patient who's on all kind of support, right from dialysis to the vasopressors to the ventilator. So we had this study which was presented by the Stewmer et al., and they classified clinical phenotypes on the EHR data. So the that is electronic health record. So they classified as alpha, beta, gamma, and delta. So if you look into the ribbon diagrams, we had the alpha, which has the less laboratory abnormalities and the less vasopressor therapy. Beta were mostly the older patient with the chronic comorbidities, and the most common organ involved was the renal, that is the kidney. Gamma was a young patient with hyperinflammation. Delta was a patient with liver dysfunction, septic shock. And if you look into the biomarkers requirement, alpha phenotype had the lowest biomarker expression and least organ dysfunction, and the delta phenotype had the highest inflammation and endothelial and renal injury. And of course, the 28 and 365-day mortality pattern also was consistent across the RCTs when it was used across the access, progress study, and the process. If you look into here as well, where the various IL-6 or the ratio of IL-10 to alpha phenotype and the ratio of tissue necrotic factor, which has been used in different parameters, whether it be in the MS or the access or the progress in the process. If you look into this, delta phenotype always had the highest level of the IL-6 or IL-10 or tissue necrotic factor when it comes to the alpha beta marker. And when you look into the heat map, also the ratio of additional biomarkers in this heat map chart. So again, the alpha biomarker, alpha variant at the lowest of the biomarkers as compared to the delta variant, which are the highest value of the biomarkers. Same was true with the other studies. So sepsis phenotypes are also known to have the hyperinflammatory type, immunosuppressive type, and the mixed suppressive type, which shows the features of both phenotypes. Now let's talk about the landmark studies when it comes to the hemoadsorption. So as of now, what you understood that the trajectory pattern of the response to the immune response in case of the sepsis and septic shock is different. We have the innate immunity, then we have the acquired immunity, and then we have the immunosuppression phase. Also, the sepsis patient have the different phenotypes. There's a delta phenotype which has the highest inflammatory response, and compared to the alpha phenotype which has the lowest inflammatory response. Now, when you talk of the different landmark studies when it comes to the hemoadsorption, so we had the UFAS trial, which is a randomized control trial, and it was studied in the abdominal septic shock patient. And what was used was the polymyxin B hemoperfusion. So, of course, it was a positive study. It showed the reduced mortality, that is 32% versus 53%, with improved hemodynamics and decreased organ dysfunction. This was published in JAMA in 2009. So, we break down this into it. So this is a multi-center randomized control trial, which was studied in 64 patients with a septic and that time it was severe sepsis and or septic shock who underwent surgery for the intra-abdominal infection, and the 34 patients were in the polymyxin group and 30 patients in the conventional group. So what it showed, there was a hemodynamic improvement at 72 hours. Organ dysfunction improved in terms of the improved SOFA scores, and of course there was a mortality benefit as well. But caveated studies were terminated early based on predefining a stopping rule. So the exact number to treat the patient were not achieved because they found it's very much beneficial. Followed by the Abdomix trial, which was the early use of polymyxin B hemoperfusion in patient with septic shock due to the peritonitis. And again, this was also a prospective multi-center RCT conducted in 18 French ICUs, and they studied around 243 patients with a septic shock, which was enrolled within 12 hours of emergency surgery for the peritonitis. And here the no benefit was demonstrated. The 28 mortality in therapy where the hemoadsorption polymyxin B filter was used along with the conventional therapy versus the only conventional therapy, the mortality benefit was not seen. Then comes the UFAS trial, which was again the randomized trial of polymyxin B hemoperfusion in septic shock with elevated endotoxin levels. So this was a study which was used where the endotoxin activity assay was used. So it was very objective parameter to consider. But again, there was no significant mortality find, and the post-hoc analysis showed maybe. So what happens is eventually they found out in endotoxin, when they use this endotoxin axis, the filter which was used was beyond the capability of clearing the endotoxin when the levels are more than 0.9. So they underwent a post-hoc analysis and they found out when benefit was observed when the endotoxin levels are in between 0.6 to 0.9. So maybe this is beneficial in higher inflammatory markers. So this filter did not have the capability to clear the markers endotoxin when those are beyond 0.9. So this is why there was no benefit seen. So again, the same study where the 450 critically ill patients are seen, and there was no reduction in the mortality, as well as the statistical significance was not really high. But in the subgroup, as I told you, because this was using the endotoxin axis, so the patients who were assigned to the therapeutic group when they had the endotoxin assay more than 0.6, but the filter did not have the capability to clear it when the endotoxin assay was 0.9, and this is why we had the negative outcome. So when they had the subgroup analysis of 0.6 to 0.9, there was the benefit which was seen. So comparatively, these all are the studies, UFAS, Abdomix, and UFAS, and they all, UFAS 1 and 2 have the positive outcome, but the UFAS and Abdomix have the neutral outcome. When we talk about the meta-analysis, which was pooled data from 17 studies, including these, and eventually they had more than 1,800 patients included. So it showed the mortality reduction, hemodynamic improvements, and the reduced vasopressor requirement. So what we overall come into is, as the sepsis has the temporal way of behaving from the pro-inflammatory phase to the anti-inflammatory phase to immune paralysis, the same would be true for the cytosorb application as well. So early phase, maybe there will be the potential benefit for cytokine removal and dampening excessive inflammation may help. Now, followed by the late phase, where we have the harmful effects like predominant because of the immune suppression is already there. So if we add on to the cytosorb in that phase, the further immune paralysis will get worsened, and then that will increase the chances of secondary infection and the poor outcomes as well. So the clinical recommendation would be to monitor immunological markers and consider HLA-DR expression before therapy, and the more research will be required in that area. So patient selection is very important. So who benefits important is early septic shock patient who present within 24 hours. We know the markers are very high at that level, and hyperinflammatory phenotype, maybe the delta phenotype, where the IL-6, IL-10, and tissue necrotic factor levels are very high, they would benefit more from these kind of therapy. And patients who have the moderate endotoxemia, because 0.6 to 0.9, because beyond 0.9 the filter did not have the capability to clear it. And of course, it has been studied very widely in abdominal sepsis, so particularly beneficial in peritonitis and intra-abdominal infection. So future direction, of course, we need a biomarker guided therapy, and personalized approaches, as we discussed, is what required. And we need to know the more advanced technologies which are more selective and adsorption material integrated monitoring techniques. So takeaways, timing is very critical. Patient selection, if we get to know which phenotype it is very much important. And we also, and this is not the modular therapy which works on its own. So there has to be an integrated approach. This is a part of comprehensive sepsis management, not as a standalone therapy. And the evidence quality is very strong for the septic shock patient and early shock, and more research is needed for other scenarios. So thank you very much. I believe I have cleared the doubts regarding the hemoadsorption therapy in the septic shock. And thank you. Please subscribe to my channel and keep listening to more talks. Thank you very much.